Hello everyone, and welcome to the Successful Return to Work with Chronic Pain, Negotiation Strategies for Stakeholders webinar. My name is Tanya Hyde, and I'll be moderating the webinar today. Our speaker today is Dr. Elaine Wainwright. Elaine is a senior lecturer in applied psychology at the Bath Spa University. Her research interests lie in two main areas. Firstly, work health and well-being, and what makes people respond so differently to objectively similar working conditions. And secondly, the effect of pain on people's working lives, mental health, and attentional processes. Elaine's publications investigate the problems and successes of the doctor-patient and employer relationships when someone has been off work due to pain. She's also building a research interest into resilience in the face of pain. And I will hand it over to you, Elaine.
Thank you very much, Tonya, and I would just like to say thank you very much to the Institute for inviting me to speak. And final thank you to all my co-authors and supervisors. They're all based at Bath University, where I have an honorary fellowship. So I'd just like to thank very quickly Chris Eccleston, who's the director of the Bath Centre for Pain Research, and Edmund Keogh, the deputy director, and Dr. David Wainwright, who convenes the Work Health and Wellbeing group. And our research was funded by a completely unrestricted studentship from the University of Bath, followed by an alumni fund grant. So it's just a piece of work they were interested in having done, but essentially there were no strings attached. So what I'm going to talk about today for about 45 minutes, briefly going to have a look at some of the ideas around whether work is good for us, what chronic pain is, and the context in the UK, having looked at other countries' issues around this as well, of moving from what you call the sick note to the fit note, but I'll talk about that in a minute. Then I'm going to move on to look at some problems and some solutions that we found when we interviewed doctors and patients, and ditto between employers and employees, and finish with some thoughts about where we could go next. So, when you think about work, one of the questions we had to think about when we're researching why somebody might need sick leave for chronic pain is whether or not work is actually good for us in the first place, or whether or not it can exacerbate issues or even bring them on. And I think, you know, we all feel like this a little bit. Sometimes we've just come back from Christmas, whatever. So despite feeling like this, actually a big review was done in the UK by Waddell and Burton in 2006. It's not a systematic review, but it's a very comprehensive, well-respected, well-recited review, looking at whether work is actually good for us. That picture there is meant to be some happy workers. And they showed that it is, for the overwhelming majority of people, being in work is better than not being in work. And they specifically looked at musculoskeletal disorders within this review, which we used as a proxy for chronic pain. The way the UK collects data on sickness absence, musculoskeletal disorders can actually be used as a very good proxy for chronic pain. So this review found that for the majority of us, work is really good for us as long as it is, and this is the sort of key thing to bear in mind, quote, safe and accommodating, unquote. And the safe bit is not too hard to understand. They look at physical safety as regulated by the Health and Safety Executive. The accommodating bit tends to refer to relationships people have with line managers, which can obviously be pretty tricky. Dame Carol Black, who's an academic but also works for the UK government, has done a lot of interesting work at the transgenerational effects of worklessness, showing that even your grandchildren can have negative financial and nutritional, for example, effects if you're out of work. And interestingly, there's been some other research done showing that early return to work interventions didn't lead to any higher risk of recurrent or increased sick leave. So in the UK, all of this body of research kind of came together to say, okay, for the majority of people, good work is good for us. However, against the backdrop of that, this is what was happening in England, UK, sorry, to our incapacity benefit rates. So you can see they were absolutely shooting up. There's some really interesting questions I haven't got time to go into particularly now about why, but if anyone's interested in that, if you see, for example, sociologists such as Frank Furedi, they've talked about in the past when people were unhappy with work, they would become politicised and unionised, whereas nowadays there's a much more individualistic, medicalised response to not being happy with work. So that's one explanation of why these rates have shot through the roof. In about 2006, so just before it started to calm down anyway, the government here decided they really had to take action. And at its peak, just to give you an example, 26% of all people in the UK who were claiming incapacity benefit from work were suffering from musculoskeletal disorders. That was the second biggest reason for being off work, and it still is at the moment. And that's about 500,000 people. So there's a great humanitarian issue if you believe that being in work is generally good for people. And there's also obviously a fiscal issue for the country. So the government was very interested in reducing incapacity benefit rates. What they did, I mean, even the hardcore proponents of work being good for you do acknowledge that sometimes sick leave can be appropriate. Nobody is saying people shouldn't have time off work. But other researchers, again, Waddell and Burson, in an earlier publication, were making the point that once you've been off, for example, for 12 weeks, statistically your chances of going back drop. And once you've been off for a year, it's extremely difficult to get back into any job at all. So sick leave can be appropriate, but there are interventional points where it's very good to try and really think about whether or not you could help someone more to return to work. So as part of this, what our government did was go from a sick note, which essentially said, can you work, can you not, and it was called the sick note, to a fit note in 2010. You can see a picture of it there. And that went electronic in 2013, it was actually in the end. But the basic premise of this, it was based around the idea that linguistic change might lead to behaviour change, which you might think is a bit simplistic, but there was some evidence for that. So it was meant to focus on capacity and not incapacity, and focus on what people could do rather than what they couldn't do, and to make the point that one doesn't have to be 100% fit to return to work successfully. And you can see in the biggest box, the doctor is meant to, having consulted with the patient, think very seriously about whether there are things the employer could do to assist that person in returning for work. So it might be, for example, where you can see altered hours. A good thing for chronic pain patients is often not to travel in the rush hour, not to have to commute at those peak hours. Or it might be a really simple workplace adaptation in terms of one of those expensive desks that go up and down, that sort of thing. So the government created this new note. And they also put a lot of money into a national education programme for all stakeholders, employers, unions, employees, doctors, interesting, not just general practitioners as well, but consultants. For example, they did it via the Royal College of General Practitioners, but also other Royal Colleges that we have in the UK for healthcare professionals. So this big thing was rolled out in 2010. Unfortunately, if you look at some recent data, if you look at the blue line at the top, there hasn't been much of an impact yet on rates, but I'll show you some of our data which maybe can give some clues into why it's not quite working and what we might be able to do next. So that's the backdrop, that's the sort of end of the first chunk of information I wanted to give you about it is stated in the UK that as long as your work is good, safe and accommodating, then generally it is better for you to be in work than out. Now there are some big sociological questions there, and again some of those the doctors raised themselves, which we'll come back to. So we were interested in mapping the fit note and this new idea that good work is good for us onto chronic pain. Now why chronic pain? Essentially because it's such a good example of the kind of medically unexplained symptoms, to quote work by Peter Salmon and others, that general practitioners in particular spend an awful lot of their time dealing with. I'm aware of my audience, so I won't be too lengthy about this slide, but it's really interesting when you look at definitions of chronic pain. This is one from IAF, the International Association for the Study of Pain, and I really like it, and it's very interesting because straight away it's saying it's unpleasant, it's sensory, but also it's emotional, and it's associated with actual or potential tissue damage, which really nicely encapsulates the idea of catastrophizing and fear that many chronic pain patients suffer in terms of making their pain worse. And I also say, or it can even be described in terms of such damage. So they're acknowledging that whether or not there's a biological marker that a GP or a pain consultant can see, there may well be things going on. And if someone is suffering, it's interesting, if you look at the Oxford Handbook for General Practitioners at the moment, it still has that quotation from the 60s nurses, pain is what the patient says it is, McCafferty and co. And that's the standpoint that healthcare professionals are meant to take. So pain is very experiential, and it may or may not have biological markers. Waddell talks about it as being intractable, it's not responding to treatment, and researchers such as von Korff and Miglioretti are very keen to emphasise how it is a very complex dynamic process. It fluctuates, and that can obviously be potentially very tricky when you're thinking about going back to work. So that's just one brief slide about what I mean when I talk about chronic pain. Another way of thinking about it is simply when people have suffered pain for over 12 weeks is another definition that comes up in a lot in the literature. So when we think about this process of sickness certification, in the UK some people call it that, some people call it sick leave, some people call it getting medical certification. If you're thinking about that process for a chronic pain patient, the background literature to this is essentially, unfortunately, one of conflict and negotiation. It's that because of this problem that there's often a lack of observable pathology, you get into notions of contestation very quickly. And it's quite interesting, if you even look back to Talcott Parsons in the 1950s and his work on the sick role, a lot of that comes up. So in the sick role, the patient, just to give you one example of an element of this, can temporarily withdraw from duties as long as they seek legitimate help from a healthcare professional, abide by it. But then you want to get better, and it can be quite difficult, although people are doing it, to apply the sick role to fluctuating conditions such as chronic pain. And there's a huge literature on the stigma that chronic pain patients suffer. I've referenced Goffman there, but more recent work by Joanne McParland at Glasgow or Chris Eccleston in Bath still show these notions again and again of who's to blame for pain, and essentially the person starts to have a good track record and eventually people start to get fed up and query it. There's a lot of difficulty for the chronic pain patient surrounding if there's any issue with no observable pathology. On the other hand, for the doctor, in most countries, including the UK, the doctor's legitimacy actually depends on the state, and they are sanctioned and licensed by the state, and that can be removed. And obviously they've got to balance what they truly consider as their patient's best interest, but also in England they have this gatekeeping role where they are the gatekeeper to the incapacity benefit. You cannot get this particular type of social security unless you have the sick note or the fit note. And GPs do, if you look at it epidemiologically, they sick list almost every day. This is work by Gwynellian Wynne-Jones and co. and her group up in Kiel, and most of them report this is very challenging and contentious for them. So there's a lot of issues around a patient going to a doctor asking for a sick note. It's not always the way people think. My top bullet point here refers to a systematic review that did say that in general lower back pain patients actively seek sick notes, and other work by Hussey in Scotland and Hugh Graham and Carl May in Southampton talk about it occurring on demand, and you feel helpless as a doctor, you don't know what to do, you don't really know how to help this intractable problem, but one thing you can do is give the person a sick note. And also one of the things we found, I'm sort of preempting the data here, okay, supposing work is really good for 90 to 95% of us, but what if your individual patient that you're eyeballing across the desk actually falls into the minority for whom work is, even good work, is going to lead to a worse health outcome? And there's some really interesting work by Wilkinson and co. on the idea of suffering. And indeed, one of the doctors we interviewed made this point very clearly, which I'll come to. And Carol Cool and co, working in Nottingham, have found that sometimes pain patients are very frustrated actually by doctors who they feel rush to sick list them in lieu of anything else to do. So it's you can see it's a very, very tricky area. And what we are particularly interested in is how would the Fit Note and the education programmes initiatives surrounding it affect GP-patient relationships. I'm going to present data to you from two main studies we did, and the first one interviewed doctors and patients about this. We were particularly interested in investigating experiences that these two groups of stakeholders have when medical certification is being negotiated. And it also wants to explore their views of the new policies that the UK has got and whether or not they thought they would actually assist in making this process a bit easier for all concerned. Okay, so again, I think I'll be quite brief about this, but I can come back to it if anyone's particularly interested in it, because these next two slides are very methodological. But ontologically, we chose to do a qualitative study. I mean, there are obviously other ways of looking at this. Work by Carol Cooligan and Gabby and co. have counted, for example, elements of things people write on a sick note, and that just done extremely good quantitative work on this. But we were interested in the idea that what is it to have an acceptable level of pain in order to be off work, and we took that to be a socially constructed process that goes on between the doctor and the patient, influenced by external actors such as the pain patient's family and their boss, things like that. So we're essentially taking a symbolic interactionist point where we're looking at trying to understand what the purpose and cause of human action is, a large endeavour. But we're doing a qualitative study here because we want to enable this kind of in-depth exploration of what is going on in a consultation and how that's influenced by things around it. This is my slide that says, I know there are some issues with this, so again I can come back to that. But just to give you a really simple 2 points from that slide. One is actually we asked people who'd had a period of sick leave, and it could be up to a year back. So there's obviously some issues with memory and with interviewing in that sense. And I think we do have to acknowledge from a constructionist point of view that we as researchers are putting our slant on what these things mean. So there's an issue around that as well. But we did what we call grounded theory, which some may well people know about constructivist grounded theory, where essentially you take your day, so we interviewed people, we audio recorded it, we transcribed it, and then all of the research team, one person, which was actually me the first time on their own, tried to code all of the data into various concepts or groups of analytical ideas, basically. And then as a research team, we got together, we had a lot of debate about how these codes may or not be valid, until we came to try and agree between us what sort of things we thought were very important to these people. So very, very briefly and in very simplistic terms, that's how we coded our data. But again, of course, I can come back to that if anybody is interested in that. We did these interviews. We had about 30 patients, about 13 GPs, which is interesting in itself. In the literature, the phrase goes, you have to keep interviewing people until you get saturation, i.e. until you don't feel you're getting any new insights from what people are telling you. And there's some work, for example, by Guest et al. 2006 that suggests that happens at about 12 people. So the doctors were as expected. By the time we'd interviewed 13 doctors, roughly the same themes are coming up again and again and again. The patients actually kept going till about 30, and I think that's interesting in its own right, because there is some tendency to lump pain patients together as a group, and actually these people felt very strongly that their stories were individualistic. So we interviewed 30 patients, 13 GPs, and we had to get ethical approval both within our university and from the NHS in England, which takes a while. That, just to give you an idea of the people who participated in the study. So the patients, it was a heavily female biased study, but that reflects the epidemiology of different kinds of chronic pain, and it was fairly evenly split between people who were managing to work full-time, people who were not working at all, either because they'd been forcibly retired or had chosen to not work, and some who were working part-time. I felt very humble. The mean, or the median actually range was 7 years that people were suffering from pain. And you can see there I've listed some of the conditions that people were suffering from. Not everybody had a diagnosis nor wanted one, but most people did. As you can see, there were 3 people who hadn't got a diagnosis and weren't worried by that, actually. Then for the doctors, it was the other way around. Most of them were men, and they had a median years practicing of 22. Most of them worked full-time, and it was fairly mixed between rural, urban, etc. Only one had extra training in any kind of occupational health. Sorry, 4 had extra training in occupational health and 1 in pain management. And one of the things we looked at was whether or not that had made much of a difference, but as you'll see, it hadn't. In terms of our results from this study, these are our 3 main results, and I'll show you some data. One is that doctors had a real double whammy, actually. They had the uncertainty of managing a medically unexplained set of symptoms or syndromes, and then they also had to map these onto the capacity for work. And that was particularly challenging when they didn't know that much about a particular workplace. But there were some negotiated solutions that they came up with to that. Patients really struggled to achieve this sick note, and achieve was a verb that they themselves used unelicited often, actually, and they felt, as I'll show you some data, that they had to sort of they had to sort of go through this process even if they weren't feeling as bad when they actually had the doctor in front of them as they had been when they were making the appointment, and they felt the system sort of forced them into that. And then interestingly, our third sort of main stream of results showed that there was conceptual agreement with all of these policies to do with the fit note and to do with good work being good for us, but there are a lot of problems, very good points that people came up with when talking about applying these new policies to their personal circumstances. So if I just show you some data from each of those 3 themes, then some ideas about what they mean, and then I'll move on to the second study, the employers and the employees. So the first theme is this sort of double whammy of having to manage MUS, medically unexplained symptoms, and map these onto capacity. And you can see some of the data there that the doctor said. So they've talked about, essentially, it's quite an individualistic process. It comes down to the patient, so Dr. Age, and some are not as eloquent as others. That was interesting because that doctor's following the pain is what the patient said it is. And doctors frequently talked about, yes, of course, they have benchmarks such as the Warzak adjectives, for example, that you can give people, Melzak adjectives, or even just VAS scales of 1 to 10. But obviously subjectivity is an issue with those sorts of issues. And they talked about pain being difficult sometimes because the signs and symptoms aren't always clear, and they talked about wanting to engage with patients' illness narratives, which is very relevant to the work of Kleinman and Arthur Frank. And practicing sort of more biographical medicine, but that's very difficult to do in the 9-minute consultation, which is our mean time in the UK for a doctor-patient consultation. And then this point sort of came up, the second 2 bits of data on this slide are particularly interesting. This doctor said, obviously I don't know that much about their work, and later made the point that, I don't think I'm showing you this precise quotation, but he said there's charity shops and there's charity shops, there's factories and there's factories. I can remember him saying this so clearly to me, and some of them have, every health and safety thing known to man is in place, whereas some of the shops are little twisty tiny shares that nobody would really want to go up, let alone somebody who's in pain. And they talked about how even if you know quite a lot about a job in general, it's actually quite difficult to know enough about a very, very specific element of your patient's job, and that was a real problem for them. Intellectual discomfort was interesting. That came up a few times amongst doctors. Some doctors really enjoyed working with chronic pain patients because of the intellectual challenges it involved, but others said quite clearly, that's a verbatim quotation, that they didn't like the lack of clarity and the lack of objectivity, which is interesting given they spend a lot of their working life having to face that. Then they talked about, okay, some patients just don't like their jobs, and that's the issue, which people did not shy away from. And an interesting point, quite a few doctors said things like this second quotation here: I'm not going to send them back if I think that'll make them worse, no matter what the DWP, which is our government department dealing with this, or anyone else says. And there was a lot of, actually, a sense of conflict. I haven't particularly talked about it on these slides, but one of the things we've looked at elsewhere is a sense we had the doctor who is legitimised by the state, actually fighting against the state in some ways. And often that's simply because they want the best for their patient and they perceive that to be in conflict between what the state is trying to do. But not always. Sometimes there is a sense of, I'm just not doing this if they tell me to. In Parsonian sick role terms, you're supposed to have the resilient, stoical patient who's going along to try and get better, and the empathetic, sympathetic doctor. And withholding a fit note, saying to somebody, no, you really need to be back at work, can actually disrupt those roles quite strongly in sociological terms. So people did use this achievement of giving a fit note to restore these roles, or what Bourdieu calls habitus, for both the doctor and the patient. Some of the possible solutions people talked about, a lot of doctors made the point that essentially they trust their patients, they don't think it's in their patients' interest to mislead them. So it wasn't that they felt in any way people were malingering or lying or anything like that, but they did talk about the fact. I can remember, for example, one particular doctor telling me about a patient's particular circumstances which were very difficult, and her job was part of that difficulty. So he was very aware for her that she wasn't trying to mislead him, but maybe being in work for her meant different things than what it would mean to him, and he was reluctant to send her back because of other issues such as her mental health as well. But doctors did essentially trust their patients, and that wasn't always mirrored back when the patients talked to us about the doctors. Doctors talked a lot about doing very active processes of renegotiating, for example, saying, okay, I will give this patient a sick note on this occasion, even though I don't actually think it's the best thing for them at the moment, because I'm worried, for example, about isolation, or I'm worried that if they're out of work for a long time, they'll struggle to go back. But I will give it, and then I'll give a shorter note next time, and I'll say, come and see me again next week, and we'll talk about it again, and I will give you another note, but it will be a bit shorter. So they were quite sort of specific about these kind of target setting strategies. Some doctors also talked about sending patients off to other doctors, such as we do have doctors who work within the benefit system only if there's been queries to whom a general practitioner can send a patient, because doctors do want very good ongoing relationships with their patients. Our sample of doctors, about half of them had actually, interestingly, contacted employers directly. Unfortunately, they hadn't got much of a response, although that might be due to sampling bias, because I didn't actually say much about recruitment, so again I could come back to that if someone's interested. But I think these doctors were recruited simply by responding to adverts, so they were interested in either pain or work or both, and they were the kind of doctors who were likely to be very proactive. And again, that doctors talked about big social ideas and solutions that might be relevant to this, such as one, for example, worked in Bristol, which actually wins lots of awards as a place to live in England, but has a big inner city area and lots of issues going on. And I remember particularly a couple of doctors there saying, look, I'm not going to send people back into these jobs that pay on or just below legally the national minimum wage and do not have pleasant working conditions. So doctors talked in quite sort of social terms about what we could do to improve pain management services, for example, put more money into them, the waiting times here are very long, and making working conditions better. For patients, I would say as a group, the patients struggled even more than the doctors because they had this idea they have to present to the doctor and they have to acknowledge that pain fluctuates, and if it happens to be in abeyance on the day they go, then they almost felt they had to enact it, and you can see there the second quotation from patient 1 talked about that. We're supposed to be able to ring up if it's an emergency and get a doctor's appointment on that same day, but it doesn't always work. There's a lot of news right now in the UK about our NHS and having one of the toughest winters it's ever had, so it can actually be very difficult to see a general practitioner when you want to. And patients didn't use the phrase illness deception, but obviously that's a phrase in the literature, and essentially that's what they were talking about, that they felt they were engaging in some kind of fiction to show the doctor how things were for them at their worst, even if they didn't feel that at the point they were presenting. So that was very tricky, and it sort of gave rise to this mutual process of scrutiny in which the patient felt the doctor was very actively surveying them for signs of illness authenticity, and in return the patient was surveying the doctor for signs of being believed. And sometimes that worked. I remember one doctor saying, I don't care why my patients are here to see me, I don't care if the pain is real or not, so that's his phrase, not mine. What I care about is that they're suffering. But you could see that his patients were responding to him and they could tell that he really did care about them. But this particular data from a different patient did not feel like that at all, and as she says, she felt like a criminal. She felt like she was engaging in some kind of almost fraudulent behaviour, even though it wasn't. And again, this issue of the struggle to achieve legitimacy led to a really strong disruption of these ideal roles that I talked about earlier, away from the supportive GP and the resilient patient. So this particular person here was talking about how you have to scream and shout, you literally have to scream and shout and cry in order to get what you want, although I don't think there was a single incident in which a patient felt they in the end hadn't got what they want, either they hadn't got signed up if they didn't want to, or conversely, it wasn't always that way. They had got their sanction, their medical sanction, to go back before. So it wasn't that they couldn't achieve their overall end, but they felt they had to behave in ways they didn't want to behave as a patient in order to get there, and that was very difficult. And I think the only new point on that slide is patients wanted their own accounts to be centralised, going back to this idea pain is what the patient says it is. And although doctors were very interested in that and very up for it in terms of trust, doctors, as I said, did experience some intellectual discomfort because they really wanted some more objective measures as well. It's very difficult. Then the last set of data from this study looked at the idea about whether or not people even agreed with the whole fit note proposal in the first place, and the whole idea that safe and accommodating work is good for us. And what we found is that everybody, every single person we interviewed did agree with this in theory, which was interesting because we didn't actually expect that, but they did. People talked about obvious therapeutic, socially and financially, therapeutic benefits of work. People talked about work being a normal thing to do, so it allows you as somebody who's suffering not to deviate from perceived social norms. But the last data on this slide, again, I can remember this person very particularly, who was a graduate who had a very good job, who was working full-time but felt that they could not do absolutely anything else at all because their job was so demanding. So that was a sort of another big issue that came up. That was a real problem with applying this policy to this person's life, that she felt she was not deviating from the norm, she was doing what the government wanted, she was doing what society wanted, but having absolutely no fun and absolutely no life at the expense of that. And the middle one, again, is an example of a doctor not being able to apply this belief. She said, if people with chronic illnesses can be normal, great, but she actually used this phrase about herself, I'm soppy soft, and she felt that if somebody didn't want to go back to work for whatever reason, she would go with that. So people struggle to map this conceptual agreement onto what was happening for them personally. I think what we sort of concluded in some of the work we've published about this is doctors were interested in changing how patients conceptualize illness, and they were interested in the evidence base that work is good for us, but they didn't really employ that. They didn't really sit and talk about that with their patients. What they used more was this tacit knowledge of persuading and negotiating, which they developed over time. And in the UK, the latest iteration of the guidance for fit notes, there's a brief screenshot of it there, actually recognises those kind of soft skills, whereas the first set of guidance that came out was much more about talking to your patients that work is good for them, implication in case they don't know that. But it's moved away from that, and it's more about building relationships and sustaining relationships with your patients now, which is interesting. But I think we need to do more on this. There isn't very much out there that we've been able to find about whether or not the sick listing communication strategies could be changed, could be improved to try and make people feel better about it. Because as I've said, really, one of the big summaries we found is people get what they want, but at the cost of feeling very bad about themselves. They feel they're not being a good enough doctor in some way because they are not really helping the patient in a more fundamental way, or they're not being a good, resilient patient. And some very recent research that just came out by Shields and Co., and also last year by Carol Cool, found that the fit note hasn't really changed this at all. So I think we need to do some more work on what kind of strategies people might employ in consultations. And one thing we didn't do that would be very nice to do is get everybody's ethical permission to record them and see what is going on rather than what people said was going on. That's just a simple thing we could do. Another thing I think we need to do in this country, I'm not quite sure, it'd be interesting what you think about how this goes down in Canada, but in the UK, that's Michael Gove, who was part of launching David Cameron's idea about the big society. But the policy, a lot of our patients made the sort of point that you can see on the screen there from patient one, that they felt these policies were entirely fiscal, and actually if the policy had been framed much more strongly in terms of what being in a good job could do for somebody, then that would have been really helpful to them. Instead, they felt like they were malingerers, and they felt very strongly they weren't malingerers, but they were being perceived by that, by the way that the policies are being framed in the media and even on websites, official government websites. So I think we need to think about framing policies as a means of generally improving what's going on for people and not simply about reducing deficit. Okay, this is sort of a few quick things about how the fit note did help, even though overall, right at the beginning you might remember I said it hasn't really. But some people talked about just having this medical knowledge had made an employer take notice of it. Until the fit note came along, sick notes didn't really have any room for a doctor to write very much to a boss, and people talked about the simple authority of having something from a medical practitioner to show to their employer being very helpful, especially if it was specific and said, for example, I need shelves, for example, in patient 28's case, and that had been helpful. I'm just very aware of the time, but I think I'll move on to the next study because I've only got about 10 minutes and then I shall stop. But one thing we haven't done that I've written in red there that we really need to do, and in fact we're doing a grant application for at the moment, is to do some very in-depth ethnographic tracking of the same doctors, patients and employers in the sample, because our doctors were not necessarily treating the patients we interviewed. They were recruited completely randomly by sets of doctors and sets of patients answering adverts, and it would be really interesting to try and compare and contrast the same people within the same sample and find out what's going on for them. Okay, then we moved on to looking at the workplace, because one of the findings I haven't really had time to present to you today from a previous thing we published showed that when the doctor and the patient are in the consultation room, they felt that the employer is in some way in the room with them, and patients would say, the doctor would say, well, I'll write this, and the patient say, oh no, don't write that because I'm worried about how it will be perceived, just to give you an example. On the more positive side, there's a bit of data that one of our patients said that it might send a message, one of our doctors said from 2011 study, it might send a message to employers, the fit note might, concerning duty of care. So it was interesting in that 2011 study how many doctors had seen the fit note as a way to shift employers' practice as well as their own, which is how it was intended by the government. So what we now want to do is have a look in the workplace at employers and employees' experiences of managing return to work after someone had been off, and again looking at whether or not the fit note had been helpful and so on. So we did the same kind of study, only this time it was 26 people interviewed with a semi-structured interview. same process of a constructed grounded theory, analysis and ethics. And just again to give you a brief idea of who the people were that participated, if you look at the employees, you can see that gender was pretty much, well, from both employees and employers, there were slightly more men than women taking part. This time it was interesting because we put the same ad up, just saying on, for example, on things like we have local business forums where the university is, and we'd put internet ads as well. And we had asked for either people to be an employer who had had direct experience of managing sick leave for chronic pain, or for somebody to be an employee. And what we found was out of the 26 people we interviewed, there were actually some pairs that came up, which was interesting. For example, we'd interview an employee who would say, look, I think, you know, my boss, I've spoken to them about the fact I'm in the study and they will talk to you as well. So we had a couple of snowball pairings where we did get to speak to the same employer and the same employee within the same set of sick leave. But most people, again, were separate, so we were talking to unrelated employers and employees. You can see there's a huge range of where they came from, and we were interested in whether or not a large company would be able to cope better because they have better occupational health resources. And we found actually that made no difference. The key thing turned out to be relationships. One of the most contentious pairings, and it was a direct pairing, was from an enormous organisation, and all of the huge resources didn't seem to have made any impact on this very difficult employer-employee relationship. But we were interested in the size of companies, so we had looked at that. And then we looked at the kind of conditions people were suffering from, just to give us a rough idea. A huge range in the number of people working for that a line manager was directly responsible for, so perhaps that's not terribly useful. And then there are 5 brief results I'll talk through, and then a brief discussion conclusion point, and then open to questions. But the first thing we found really simply was that both the employer and the employee, in order to make a successful return to work, they just need to be very, very explicit about rhetorical devices, for example. This is the simplest example I can give you, where an employer would say, you know, I'm always talking with this person about, do you want me to ask every day if you're in pain? Do you want me to ignore it? And we come in every day and we say, how are you? And actually, this was a direct pairing, and the employer in this case felt they were doing the right thing by solicitously inquiring after their employee. But the employee had actually said, no, I perceive this as intrusive, I don't want you to do it. And also we have that rhetorical assumption, don't we, that you say, how are you? And we say, fine, thank you, or we do in British culture, even if we don't mean it. So this rhetorical device was taken to be A, intrusive, and B, useless by the employee, whereas the employer felt they had to do it. But once this pair had talked about that, and the employer found that this didn't need to be said every day, that in itself, a simple thing like that, made this process much better. So instead of starting the day off with both sides feeling a bit disgruntled, the employer just didn't say it anymore, but made it clear that they were willing to listen if their employee wanted to talk to them about how they were that day, which sometimes they did. So we found that's just a simple example. You have to make very implicit things explicit sometimes. Another thing we found is employers routinely employed a very holistic knowledge of their employee to assess the authenticity of illness claims that the employee was making. Now this is obviously great if the employee has a good track record, and you can see if this data here that this manager says, I know he'll do his best, he always does. But this manager particularly refers that to pain, because they're talking in the context of not always being able to see what's going on, but really trusting the employer and saying, I think the most important thing is that he, the employee, knew that he could say that that was enough and he had to stop, and we'd believe him. So there was a real positive sense of using someone's track record. It didn't necessarily have to be a long track record in terms of hours and time that they'd been in the company, but simply that their sort of holistic understanding of what the employee was like was very helpful for the employer. And that doesn't get talked about very much in the guidance and in the literature. What we found is in return, employees mirrored this kind of idea of trust, and they talked about the physical aids that they receive as being very important, for example, better steps to get up onto the shelves that I mentioned earlier, or expensive desks, or even just simple gel wrist mats and those kind of things. But what we found is, even though it's interesting, because mostly in the UK a company doesn't have to pay for those things directly, they buy it and they claim back about 80 or 90% of it from the government. And often employees didn't know that, and even when they did, it made no difference. The fact that somebody in the company had bothered to sort this out and get it for them had made them feel extremely valued, and that had made a huge difference above and beyond the physical help that the item was conferring. The fourth thing we found was that people needed to be really flexible about the guidelines that exist in the UK about improving the return to work process. And just to give you one quick example of that, in the same way that I think doctors and patients, I talked about them moving away from their ideal role as a resilient patient and a sympathetic doctor, very similarly, employers talked about a balance between the business bottom line but wanting to be humane, and employees talked about wanting to retain the good track record that they have or increase it, or generally to be seen as being a good employee. And one of the things it says in our guidance is that an employer has to be very careful about how and when they contact you when they're off sick. And good practice says obviously they should contact you, but there are quite prescribed ways about doing that, and one of the things is it shouldn't be done too little, but it shouldn't be done too much, and that has to be negotiated. And in this particular piece of data that I'm displaying to you on the screen now, an employee wanted to be rung almost every day, which most people would consider as too much, and indeed the guidance suggests, our guidance suggests it's too much. And the boss actually didn't want to do that because he felt it was intrusive, and he felt the employee was kind of running before he could walk and would come back before he was ready. But actually the employee was able to explain to his boss that he felt much more in control if he was contacted briefly every day with a quick update, and maybe he could say a few things, because he felt things were being, he's used this phrase, taken care of in his absence, and he wasn't going to come back to this huge mountain of emails, and neither was he going to come back to approbation from colleagues. He felt this for him really managed the process very well. I have to say there is some fear, or there was in our sample, for the employers about deviating from any kind of guideline that's out there, guidelines from the government and the unions, for example, because there have been tribunals about this. But in our sample, people did want, again, going back to maybe the first result about making things explicit, they wanted these things to be very explicitly negotiated. And then finally, some positive news about the fit note. Almost everybody was indeed positive about it and responded to it in the way the government hoped in terms of the linguistic focus on fit. If you look at this second big bit of data here, this person said, this is an employee, it was so lovely to see on the back of that note, fit for work. It felt like a victory because he'd been unfit for such a long time, and that spurred me on to get back to work. So this employee is a perfect example of someone for whom simply focusing on fitness rather than unfitness had psychologically made a tremendous difference for them. And employers routinely said things like this first short bit of data here, the fit note is better because it opens things up. People talked about it being interrogative, about a conversation, and a lot of people, a lot of employees talked about it being very authoritative as well, in a good sense, in the sense that because it's a more expansive note and because doctors can write more on it and more specific things on it, they felt it reflected a more in-depth conversation they'd had with a doctor, and the doctor had agreed things with the employee that they could then take back to the employer. And this person ended by saying, I felt I had more to tell them, the employer, more than just, oh, I'm off sick. I'm sick because the doctor says I'm sick, which is the old line. But in this sense, he's the one using the word interrogative. He's saying the fit note reflects these talk that we've had with the doctors, which I think is a really important point to try and get the communication from the consultation back to the workplace. So in conclusion, we found there was a lot of positive mirroring between employers and employees about trust and about flexibility. And this mirroring really helped to balance competing narratives, competing roles that are going on for people between trying to be humane and a good employer and also everybody being aware of business bottom lines. And Debbie Cohen, who I cite at the bottom there, has done some interesting work showing that shared decision-making is very important in return to work, and this kind of mirroring seemed to really help that feeling of the decisions being negotiated and shared and renegotiated, which we found was very important and very helpful for people. I think the track records in our sample were good, as I've said. People tended to use them very positively, but obviously this is a small sample, so we have some limitations in terms of generalizability and size. But in our papers, which you can find if you're interested referenced, we did provide a very thick description of how we collected and analysed the data, so people could try and decide if the findings were at all applicable to their own areas. So I think these are the positive things. To finish, this is what we need to do next, certainly in the UK. We need to be very open about tacit phenomena and rhetorical devices as a way to enhance the communication between stakeholders. We need to use guidelines flexibly, and I think our policymakers, our health and safety executive, could further highlight that it's okay in some circumstances to do that, obviously within limits. And people in Australia have done a lot of interesting work about how very multifaceted approaches are useful when you're trying to think about back pain, for example, belief and behaviour. And I think the FitNote really fits well with this idea of multidimensionality because it has these different benefits. It has this biomedical authority that can be very useful, and it has this positive language. But I think what we do need to do is do a lot more work. This is a small sample, and there was a lot of pre-existing trust, and we need to do more work where there isn't that. I've already said I think we need to do this ethnographic tracking of the same groups. And there's some very radical suggestions in England at the moment about changing the nature of sick listing altogether. Occupational Medicine Journal, British Journal of General Practitioners are having debates about whether or not to take it out of general practitioners' hands and put it firmly in occupational health. And the very final thing, and I'm very aware of time, but I mentioned, or Tonya mentioned in the introduction, I've become very interested in resilience. And I have per se as a concept for people suffering from chronic pain. And we know, for example, from really fantastic work from America, you can see just one little slide that I've borrowed from Sturgeon, Smith and Zutra, that resilience factors are incredibly important and can be independent predictors for people in pain of positive social interaction. But there's very little known I can find at all about how someone in pain who's resilient, how this might work for them in the workplace or in return to work. So I think I'd like to find a lot more out about that. And that is everything. So thank you very much indeed.
Wonderful. Thank you very much, Elaine. That was a wonderful presentation. Very thorough. and very good presentation of a variety of sides of the conversation as well, which I think is really fascinating and we don't often get.
Thank you.
Let's see. I'm going to go ahead and take questions now. So for those of you online, you can type questions that you might have for Elaine into the questions box, and I'll read them out loud. The first question we have is, did they measure responses from GPs in a before and after for this research regarding the return to work?
Not in a systematic way, as in this is a qualitative study, and we did the interviewing just after the FitNote had come in. So doctors did spontaneously talk about sick notification both in the old system and the new system, and that's where we found, for example, for patients, they actually felt it was more useful than doctors did. Both groups talked about it before and after. But just to give you a quick example, the patients were the ones who were particularly keen on the linguistic change from sick to fit. The doctors found that had less impact in terms of overcoming this issue I talked about the tension doctors feel between doing what's best for their patient and feeling that the government is wanting them to sick list less, and that's the bottom line.
Very good. And someone was wondering if you could go back to the picture that shows of the actual FitNote.
Sure.
They were wanting to look at that a little bit more.
That's right, near the beginning. So here it is. I put that up there. I mean, one of the things I would say about this is a lot of researchers and other people interested in this in the UK are very cross because the FitNote doesn't ask the patient what job they do. So when you collect data for quantitative studies that people are doing, a lot of people I've spoken to, a lot of researchers said that would just be such a useful thing to know because we don't know anything about that unless there's something the doctor's written in that big box that helps with that. But you can see the four main areas that are meant to be looking at whether or not a phased return can be useful. Altered hours may or may not be the same as that, and ditto, the other two boxes look quite similar, but the amended duties might be quite radical, although that had problems. Again, somebody said to me, I won't tell you the name of the company obviously, but you'll guess from the comment, they said, well, there's, I can't employ a baggage handler as a pilot and I can't employ a pilot as a baggage handler, so there are limitations with that. But you can see the four main areas that doctors are supposed to comment on, and also you can see that there's a time that they can put in underneath that big box, and they can also say whether or not they need to see the patient again at the end of this period when this FitNote runs out, which is a useful thing.
Very good. We are still waiting for any new questions.
Sure.
Let's let me see. I think I just got an email with a question.
Okay.
My understanding in the UK was there have been some GP training modules, for instance, on back pain. It would be interesting to track differences between those that have had specific educational training versus those who have not. Was a GP education exposure considered in this first study, or in the first study?
Yes, well, we asked people, we asked them what formal training they had had. I showed one slide that only 4 people had had occupational health diploma training, and one person had had training specifically in pain management, but not in back to work as well. But I think what your interlocutor was particularly referring to, and I actually was allowed to observe some of these, was the Royal College of General Practitioners have set up discrete modules that GPs can attend that are just a few hours on how to use the fit note and on return for work. And it's Debbie Cohen's work. If they look up her, she specifically evaluated that and found it has a positive impact. In this study, we didn't look at that exact module, but what we did look at was whether the effect of having the occupational health diploma in itself had been helpful. And whilst in general it had been, I think the biggest caveat with that was this data I referred to earlier where people said, you just need to know with such precise detail what kind of charity shop it is that, for example, that the person's working in, and what kind of managers they have. And a lot of that simply came back to having the time to talk to your patient, whether or not you had any training and whether or not you had a long-term relationship with your patient. Because the other thing, very briefly, that the UK was thinking about at the time we interviewed these doctors, although they've backed away from it at the moment, was putting general practices together in much, much bigger outfits and offering patients 24/7 appointments, whereas at the moment most doctors are kind of 9 to 5 in the UK, most general practitioners are anyway. But there was a lot of resistance to this, interestingly, from both patient groups and doctor groups, because they perceived that if you have these giant practices, you're very unlikely to be able to see the same doctor. You might be able to get an appointment, but it will just be with whichever doctor is free at 10 o'clock at night. And they felt actually what we need to do, in fact, Steve Field, who was the president at the time of the Royal College of General Practitioners, sort of proposed this radical idea of doubling consultation times, which initially would obviously create huge systemic problems, but he felt over time might reduce issues like this, because whether or not you had occupational training, you would be able to have time to get to know enough about your patient and enough about their job. So that was one of the things we found with this, but we didn't really focus on that. I think Debbie Cohen is the researcher that person needs to look at. I'd recommend her work to them.
All right, very good. And I think that's all of the questions we have right now. We could wait just a just a moment or two just to see if anything else pops up. Have you done much talking with other researchers in other countries around their policies around this?
Yes, and I've just literally last week been in Denmark to have some conversations with people there, but they have a very interesting different take on it, and they're considered to be very far ahead of us in many ways, and indeed they are, because they have, for example, in Denmark, they are quicker than we are overall at getting people into more specific interventions, which seem to be helpful. There's some work, for example, by David Glasscock that was presented to me last week, which he's also published on, showing that. So in Denmark, they seem to be a bit ahead of us on the game in terms of when something goes wrong, getting it right. But what was interesting for me as a researcher was the Danish researchers were talking very sociologically about the same things that our GPs were talking about here, in terms of it. A lot of this comes down to what are the working conditions for the population and how good are they, and sort of very big social questions were coming up in Denmark as they were here. But I think, for example, in Holland, they have a much more proactive system about getting the doctor, the patient and the employer literally around the table together. And we just don't do that in the UK, and there's been a lot of interest in the UK about that system, which obviously has big resource implications to do it that way, but does seem to be having some promising results.
Very good. That sounds very interesting.
Yeah, I need to find out more about that.
And then someone was asking if you would be able to send some references or links regarding the Denmark and Holland
Sure. Shall I email them to you,
studies.
Tanya, or is
Yeah, that
there...
would be great. What I'll do is I'll just add them to some resources links on the page where I post the recording for this webinar,
Okay.
and then people will be able to access it there.
Sure.
That would be very helpful.
No problem. Well, thank you very much indeed.
Thank you. And then there was one more question
Sure.
real quick. Is there much discussion about GPs using occupational therapists to assist in this process?
It tends to be, in my experience of my own research and reading other people's, that it's the workplace that initiates that. Sometimes, actually, yes, but in our research, where GPs did that, they did it to preserve their relationship between themselves and their particular patient. So they tended to do it when things were going wrong, and they essentially wanted somebody else to come in to deliver difficult messages. So that was the way it was being used. Not always, but that was the general thrust of it. But there is actually a big trial going on that the UK government's doing, where it's done an independent assessment service, it's called IAS, and they are putting a lot of money into providing occupational health therapists that doctors can refer patients onto, so can employers, to try and make this better. And these occupational health people are supposed to be independent of both the doctor and the employer, so the idea is they will not be worried about any kind of bias going on. That's just starting at the moment. I think there's calls coming out for research on that quite soon, although there's some initial data showing it has been helpful.
Very interesting. All right, well, I think we're right about at time. Thank you very much, Elaine, for the presentation. That was really great.
Thank you for inviting me. I really enjoyed it.
Absolutely. And we would also be interested in getting in touch with you once you start doing some of the research around resistance and chronic pain in the workplace, because I think that would be very, very interesting to do a webinar about as well.
That would be fantastic. Please do. The grant's got to be on 15th of March, so hopefully it will start fairly soon.
Wonderful. And then thank you everyone online for being with us today.